Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll look closely at disparities in the use of pharmacologic restraints in pediatric emergency departments. Now, we know that emergency department use by children with mental and behavioral conditions is skyrocketing, not uncommonly resulting in boarding in the emergency department, extended stays, and in our own pediatric emergency department, there are many families who use the emergency room as their primary site for addressing behavioral and mental health conditions and concerns. This isn't surprising in a complex and often challenging mental health system that is all too often overwhelmed and understaffed. Decreased inpatient psychiatry beds in the community further complicate and challenge pediatric emergency departments with extended stays of youth with behavioral and mental health conditions. So in this multi-center study described by Foster and colleagues, emergency department visits from over 540,000 youth with a primary mental or behavioral diagnosis 3 to 21 years of age were analyzed between 2010 and 2020. Over 22,000 visits, or just over 4%, involved pharmacologic restraint. Pharmacologic restraint was predicted with ages 18 to 21 years, male sex, Black race, visits starting during the weekend or overnight when staffing is usually less intense, and repeat visits for mental or behavioral health conditions. Interestingly, pharmacologic restraint decreased as average annual emergency department volume of youth with mental or behavioral health conditions increased. And this may be due to emergency departments that have more patients with mental or behavioral conditions. They may get more experience, dedicate more resources to these patients, become more comfortable in handling behavioral and mental health patients in the emergency department. Now, the authors of this article also did a deep dive and took a close look for potential healthcare disparities in pharmacological restraint, and they found that Black patients were significantly more likely to have pharmacologic restraint than white patients. This is very important, and it raises a lot of questions about possible biases that could be the result of explicit or implicit bias. And it also raises opportunities for quality improvement using standardized protocols, various quality improvement initiatives to ensure that all patients are treated the same, or at least in the same manner, and that can minimize the risk of these racial or ethnic disparities. I should mention that while we've focused primarily on pharmacologic restraint, there are behavioral interventions that can significantly decrease the need for pharmacologic restraint. This includes training of staff in how to react to youth and their families, to be proactive rather than reactive in terms of intervening before the situation gets out of control in terms of agitation and aggression. Our department has actually developed what we call a compassionate care training program, where we train non-mental health personnel in emergency departments, on medical and surgical inpatient units, outpatient clinics, group homes, and more about how to better assess and be alert for behavioral discontrol and what strategies can be used to prevent or reduce its occurrence. Part of this may involve decreasing external stimuli around an agitated patient, being attentive, checking back in with patients and families, identifying families who seem upset, or children, adolescent, their families who are nervous, who have been asking for more information, that kind of thing. The compassionate care training that we developed is really a behavioral analog to ACLS, with vignettes, role play, interactive training to become more comfortable and adept when interacting with patients with mental health and behavioral health conditions. We wouldn't expect a physician with no training at all to go in and do advanced cardiac life support. And similarly, in psychiatric behavioral discontrol in an emergency room setting, sometimes unexpected, sometimes with decreased resources, we shouldn't expect that someone with no training in the behavioral aspects would be able to just walk in and do things perfectly. My experience, our postmortems about agitation and aggression, and our work convinces me that many pharmacologic restraints are actually preventable. Now, there's no doubt that some aren't, and even with the best care, pharmacologic restraint is necessary. But more often than not, pharmacologic restraint can be prevented or at least minimized if the right behavioral policies are in place, if people are trained to be proactive rather than reactive. And some aspects can be amazingly simple. For example, I'm a child and adolescent psychiatrist. Can you guess the one word that I never use with my pediatric patients? I'll give you a hint. It's one syllable. Okay, that word is no. Because when I say no to a child or adolescent, it immediately changes the dynamic. Now, don't take this to mean that I agree and do whatever the child or adolescent wants. Quite the contrary. But rather than starting with no and getting the adolescent or child in a defensive or posture where they're immediately some kind of confrontation, I like to take that away, show the person that I'm listening to them, that I realize their concerns are valid, do what I can to bond with a particular child. Now, this doesn't mean that it always works and that you can bond with every adolescent or child. But in my experience, more often than not, this can be quite successful and can often diffuse certain opposition, certain concerns in children or adolescents. I'm letting them know that I hear their concerns. I want to address them. I want to look for ways to form an alliance. That's important to me, and I hope important to them. Obviously, much of the training in terms of compassionate care is far more complex than just not saying the word no, but the principle is the same: to train, retrain the brain, to retrain our limbic system in terms of emotions and how we process emotions, and to think proactively about approaches and how to keep everyone safe, prevent, minimize, and be ready and not unprepared for aggression or agitation. The bottom line is this is an important early paper reflecting a growing national epidemic of skyrocketing youth visits to the emergency department for mental health and behavioral conditions. The healthcare disparities are definitely something meriting attention, and we're training in implicit and explicit bias, as well as developing standardized protocols, may help in significantly reducing these biases.